our HOD and organizing committee for giving me the responsibility of conducting today's webinar. Assalamu alaikum everyone. I welcome you all to the national webinar on Urine, a diagnostic tool, organized by Department of Mahiyatul Amraz, NIUM, Bengaluru. The department is committed to shape the skilled future professional by providing high quality teaching and lab training to PG scholars. Department has conducted 2 webinars till date. So without any further delay, I would like to call our Director, Sir, Professor Abdul Wadud, for his inaugural note. Over to you, sir.
Okay, thank you. Am I audible? Am I audible?
Yes, sir.
Okay, thank you. Bismillahirrahmanirrahim. Assalamu alaikum and a very good morning to all of you. My colleagues, Professor Abid Ali Ansari, Dr. Azizur Rahman, Dr. Kasfi Hakim Ansari and Dr. Sadiq Ali और डिपार्टमेंट के तमाम तलबा तालिबात और वेबिनार के शुरका, एक बार फिर आप सबकी खिदमत में मेरी तरफ से सलाम अर्ज है। नेशनल इंस्टीट्यूट ऑफ यूनानी मेडिसिन बेंगलोर के बारे में जैसा कि आप सभी लोग जानते हैं कि ये हिंदुस्तान में इल्म तिब का सबसे बड़ा और सबसे अच्छा इदारा है। यहाँ पे मुस्तकिल सेमिनार, वर्कशॉप, वेबिनार्स, ट्रेनिंग प्रोग्राम्स, जर्नल क्लब्स और बहुत सारी दूसरी सरगर्मियां जारी रहती हैं, इल्मी सरगर्मियां जारी रहती हैं। उसी सिलसिले की एक कड़ी है ये वेबिनार, जो तमाम डिपार्टमेंट को कहा गया है कि वो कम से कम 2 वेबिनार ऑर्गेनाइज करें। शोबे माहियतुल अमराज ऑलरेडी एक वेबिनार ऑर्गेनाइज कर चुका है, ये उनका दूसरा वेबिनार है। मुझे बहुत खुशी है कि ये एक इंस्टीट्यूट का सबसे नया और फिलहाल 10वां या 9वां कह लीजिए जो इसके इनके साथ ही इसका क़याम हुआ है। बहुत ही तेज़ी के साथ अपनी मंजिल की तरफ बढ़ रहा है। मुझे उम्मीद है कि शोबे के तमाम तलबा और असातिज़ा मिलकर इस डिपार्टमेंट को मज़ीद आगे ले जाएंगे। और ये चूँकि एक नया डिपार्टमेंट है और एक ही बैच अभी तक निकल पाया है, इसलिए एक तरह से डिपार्टमेंट आगे की रिसर्च के लिए ट्रेंड सेटर भी होना चाहिए। पैथोलॉजी में किस किस्म की रिसर्च और तहकीकात हों, वो इस डिपार्टमेंट की जिम्मेदारी है कि वो दूसरे तमाम कॉलेजेस में जहाँ ये डिपार्टमेंट खुले हुए हैं या खुलने वाले हैं, अगर वो पीजी डिपार्टमेंट हैं तो उनमें रिसर्च की राहें मुतय्यन की जाएँ, ये तयन किया जाए कि यूनानी में बिलखुसूस माहियतुल अमराज में किस किस्म की रिसर्च की जाए, क्योंकि पीजी डिपार्टमेंट का मतलब है रिसर्च और तहकीक। जो इल्मी सरगर्मियाँ हैं वो अपनी जगह हैं, दरस व तदरीस अपनी जगह है। इस डिपार्टमेंट को इसलिए खोला गया है कि एक अहम डिपार्टमेंट है और इसमें अच्छी किस्म की रिसर्च होनी चाहिए। मुझे उम्मीद है कि जैसा कि इस वेबिनार का जो मेन टॉपिक वो ये बताता है कि डायग्नोस्टिक्स, यूनानी के जो डायग्नोस्टिक टूल्स हैं जैसे यूरिन, बोलोब्राज, नब्ज वगैरह, उनमें से यूरिन का इंतखाब किया गया है क्योंकि अतिब्बा ने यूरिन से डायग्नोसिस तशखीस को बहुत जोर दिया है। इसलिए मुझे लगता है कि एक अच्छा टॉपिक है और लोगों को इससे आगाह होने चाहिए कि पेशाब के ज़रिए, बॉल के ज़रिए हम कैसे बीमारियों की का आगाज़ तशखीस करें। और इस सिलसिले में कुछ तहकीकात भी हो चुकी हैं शोबे के अंदर कि यूरिन को एक पैरामीटर बनाकर मरीज़ों के अंदर तशखीसी नुक्ते नज़र से उनका जायज़ा लिया गया है। एक बार फिर मैं डिपार्टमेंट को मुबारकबाद देता हूँ कि वो इस तरह के प्रोग्राम मुस्तकबिल में भी करते रहें। अस्सलाम वालेकुम, शुक्रिया।
थैंक यू सर।
Thank you, sir, for your valuable words. Now, I would like to call our HOD, Professor Abid Ali Ansari, for welcome speech. Over to you, sir.
अस्सलामु अलैकुम रहमतुल्लाहि व बरकातुहू। आज के एक रोज़ा कौमी वेबिनार बउनवान यूरिन डायग्नोस्टिक टूल के ऑर्गेनाइजिंग चेयरपर्सन व डायरेक्टर NIUM मुकरमी व मुहब्बी जनाब प्रोफेसर अब्दुल वदूद साहब, असातिज़ा कराम, हम असरों, तलबा व तालिबात और मुल्क के मुख्तलिफ हिस्सों से टेली कम्युनिकेशन के ज़रिए जुड़े तमामी हजरात का मैं खैर मकदम करता हूँ। शोबा माहियातुल अमराज का क़याम इस कौमी अदारा में नामौलूद की हैसियत रखता है। गुज़िश्ता 4 सालों की बहारों में इस शोबा की 2 बहारें कोविड-19 के नज़र हो गई। कुल 2 सालों में इस शोबा का यह तीसरा वेबिनार है और इस साल का यह दूसरा। और शोबे के नशोनुमा में हमारे डायरेक्टर साहब का बड़ा ताउन रहा। उनके ताउन के बना पर शोबा इस मकाम तक पहुंच पाया। और दूसरा अहम रोल इस डिपार्टमेंट को बनाने और संवारने में हमारे असातिज़ा का रहा है। आज के वेबिनार में पहला लेक्चर डॉक्टर तस्फिया हकीम अंसारी का है, जो कि यूरोस्कोपी के हिस्टोरिकल बैकग्राउंड पर रोशनी डालेंगी। और दूसरा लेक्चर डॉक्टर रूही आजम साहिबा का होगा, जो कि यूरिनोलिसिस एंड न्यू टेक्नोलॉजी के उन्वान से अपनी मालूमात पेश करेंगी। जबकि आज का तीसरा और आखिरी मकाला डॉक्टर संजीदा साहिबा का होगा, जो कि डायग्नोस्टिक डायग्नोस्टिक रोल ऑफ माइक्रोएल्मिनूरिया के तहत है इजहार ख्याल करेंगी। दरअसल लेबोरेटरी मेडिसिन का आगाज तकरीबन 6000 साल कबल इंसानी बौल के तजर्बे से हुआ। जिसे 17वीं सदी तक यूरोस्कोपी कहा जाता था जिसे 17वीं सदी तक यूरोस्कोपी कहा जाता था और आज इसे यूरिनोलिसिस या बौल का तजिया कहा जाता है। आज मुआलिज मुख्तलिफ हालात की तशखीस के लिए बौल का इस्तेमाल करते हैं, लेकिन कदीम दौर से लेकर विक्टोरियन दौर तक बौल को बुनियादी तशखीस के तौर पर इस्तेमाल किया जाता रहा। लेकिन कदीम दौर से लेकर अब भी सुर्ख पेशाब खून की मौजूदगी के लिए काबिल ज़िक्र है और बिलिरुबिन या खून के मसनूआत के लिए ब्राउन या भूरा पेशाब की तशखीस की जाती है। आज के इस वेबिनार में बौल की तशखीस की अहमियत और जदीद टेक्नोलॉजी के मुतालिक से तमाम तर जानकारी दी जाएगी और मैं पुरुम्मीद हूँ कि आप लोग आज के लेक्चर से मुस्तफ़ीद होंगे। अब आप लोगों से बग़ैर ताख़ीर इजाज़त चाहूँगा। खुदा हाफ़िज़।
Thank you, sir, for such warm welcome. Proceeding further, I would like to introduce our first speaker, Dr. Tafsir Hakim Ansari, Assistant Professor, Department of Mahiyatul Amraz. She did her PG from AMU in 2014, where she was awarded 3 gold medals, and she did her PG in 2017 from NIUM. She is associated with teaching since 2018. She has published 20 research papers in reputed journals. She also presented her papers in national and international conferences and seminars. She has supervised 2 theses till now. So I would like to call Dr. Tasfia Hakim Ansari to deliver her lecture on the topic urine examination from uroscopy to the era of microscopy. Over to you, ma'am.
अस्सलाम वालेकुम।
वालेकुम अस्सलाम।
Am I audible?
Yes.
First of all, I would like to thank our director, sir, our HOD, and fellow committee members for providing me this opportunity to present my talk in this webinar. And today my topic is urine examination from uroscopy to the era of microscopy. And the contents of this talk is first I would be introducing the topic, then I will explain the status of uroscopy before the time of Hippocrates, then at the time of Hippocrates from the time of Hippocrates to Galen, then what was the status of uroscopy in Middle Age and in Islamic era, and after that in Renaissance era. Then how the chemical analysis of urine started and era of microscopy. I would be talking here, and then I will conclude this topic. My slides are visible?
No.
No, ma'am.
Please share your. Yes. Please share
Okay,
your.
okay, one second. Share screen.
Double click. Start.
Share.
अब देखिए
Is it visible
Yes.
now?
Yes. Visible.
हो गया
Slides are visible?
Yes.
हो गया
Yes, now it is visible.
Okay. So I was talking about the contents of my talk, which includes the introduction and status of uroscopy in different era, and then chemical analysis, and mostly I would be discussing here about the timelines of chemical analysis and era of microscopy. Then in last I will conclude my talk. Without further delay, I'm just going start with introduction. As we all know that in present time, there are different body fluids that are being examined for the purpose of diagnosis and prognosis of diseases. In present time, we can see urine has taken a back seat, and it is now second most commonest investigation after blood. But when we talk about the urine examination, since in antiquity it was the first body fluid to be examined, it has provided medicine with an abundance of knowledge about the workings of inner body. That's why ancient physician used to consider urine as a liquid window, because they thought it provide much of the knowledge about functions of the body in various states. For most of history, as we know, urine was a visual science. Urine examination was a visual science, as a physician used to do physical examination of urine, which we called as a uroscopy. And there came a time when urine collecting pot, which is known as matula, or we call it parura as in Unani. Then matula became a symbol of medical profession in Middle Age. Then after some time, or you can say over the time, the practice of uroscopy transformed into uromancy, and uromancy is a practice actually in which urine examination was done for fortune telling. I mean to say that urine examination, misuse of uroscopy started in Renaissance era. As a consequence of that, chemical analysis and microscopic examination of urine came into the picture. What is uroscopy? Uroscopy, actually, it is derived from the Greek words oron, which means urine, and scopio, which means to examine. Uroscopy means examination of urine, but precisely when we say uroscopy, then it means physical examination of urine for the purpose of diagnosis as well as prognosis of diseases. As advancement in chemistry and physics, uroscopy became As advancement in chemistry and physics, uroscopy became urinalysis in the late 18th and early 19th century. However, the term analysis was given by Robert Boyle in 17th century, but the exact urine analysis which we see today that comprises of the physical, chemical, and microscopy examination of urine is started in only in late 18th century. So I will be talking about the status of uroscopy, or what exactly uroscopy was before the time of Hippocrates. Then the earliest known evidence about urine examination can be traced back to ancient Sumerian and Babylonian text, where they used to assess urine for diagnosis of the different pathological condition. And they actually recorded their assessment of urine on clay tablets. There are several Babylonian terms like sinatu pizu, which means white or pure urine, and sinatu bursi, which is a term for bright red urine, or pati sinatu, that is cloudy urine. This term actually showed that they were aware of urine examination, or they used to practice uroscopy. However, they only examine the physical appearance of urine. Next we see the ancient Egyptian, where extended references to urine examination can be found in ancient Egyptian text, like in Eber's papyrus or papyrus of Kahun, in which the different urinary changes regarding the different pathological condition is mentioned. Like hematuria, they have attributed hematuria to the worms in the belly. And their urine examination actually was not limited to diagnosis or prognosis of diseases. They actually used urine for the purpose of confirmation of the pregnancy as well as for determination of sex in fetus. As there are evidences that shows that Egyptian priests used to pour urine over the mixed cereal seeds. If the germination occurs, then the test is positive, pregnancy is positive. And on the basis of the type of seed sprouted, they used to somehow determine the gender of fetus. However, the reliability of this test is not mentioned, but a similar method is mentioned in Firdausul Hikmat also, in which Rabban Tabri has mentioned a similar method, but for the detection or for the determination of the fertility of a woman, not for the confirmation of the pregnancy. As we can see in this picture that a physician is examining a urine, and in this matula, there's a picture of a baby, and a lady is being scolded or being shouted by the old lady for being pregnant. And this picture actually clearly depicts that they used to examine urine for the purpose of pregnancy confirmation, you can say. In ancient Indian period also, like there are different references available regarding urinary changes in different diseases. 20 types of urine are mentioned in an ancient Sanskrit text. Like some of them I have written here, like Udaka Meha, which is a term for water-like urine, Sura Meha, when the urine resembles brandy, and Vasa Meha is the term for fatty urine, Kala Meha is for black urine, Majja Meha for bone marrow-like urine, And madhumeha, they actually define a term, madhumeha, which is the term for sweet urine. As we know, they noticed the long trains of large black ants were attracted by sweet urine that helped them in diagnosis of sweet urine. Then we will talk about the Hippocrates. As we know, Hippocrates is considered as the father of medicine, and he was the first person who denied the supernatural powers in role of supernatural powers or some rage of angels or possession of demons in causation of disease. And he proposed the four humors as a cause of disease, or theory of four humors. He actually is credited as the original uroscopist. And there are several references that show that he used urine as a diagnostic as well as prognostic tool. When we see his text, there are references to changes in urine, and he used to evaluate urine in different disease condition. Like some of his statement, I have written here, like in those cases in which the urine is thin at first and sediment became bilious, and acute disease is indicated, or blood or pus in the urine indicates ulceration of the kidney or of the pustule or bladder, or of the bladder. And the urine is, he has written a treatise, as most of you must be aware of that treatise, that is Book of Prognostics, which in which he has some 25 sections, small sections that is dedicated to different diseases, how to prognose different diseases, in which he has mentioned. A whole section is dedicated to urine in that book, how the urine can be used for prognosis. This paragraph, or these lines I have taken from that book. The urine is best when the sediment is white, smooth, and consistent during the whole time until the disease come to a crisis, for it indicates freedom from danger and an illness of short duration. But if urine is deficient, and if it is sometimes past clear and sometimes with a white and smooth sediment, the disease will be more protracted and not so void of danger. Presence of a bubble on the surface of urine is a sign of kidney disease and long illness. So we can see, however, he has not enlisted separately that what parameters should observe in a urine, like we see in Al-Qanun and other books. But these statements, or these in his writings, we can clearly assess that he used to assess the color, consistency, volume, clarity and cloudiness, sediment, odor, and froth or bubbles. Then Galen actually refined the Hippocrates' thoughts and ideas, as we know, and he considered urine as a filtrate of blood, and he was the first person to demonstrate the kidneys as a source of urine. He used the phrase like diarrhea of urine to describe the excessive urination for the first time. And he used it, as we can see in his treatises or in his writings, clearly that he used uroscopy as a diagnostic as well as a prognostic tool. Then in Middle Ages, Middle Age actually, it roughly expands from 5th to 15th century, or we can say it's simply the Byzantine time of the Byzantine era or Byzantine period, in which a Byzantine scholar, Theophilus Protospatirius of Constantinople, which is modern Istanbul, in 7th century, he actually wrote a book exclusively on urine. with the title De Urinis. And in this book, he has explained the physical examination of urine and their clinical significance. And in this book, he has also included that the same Galen's thought that urine is a filtrate of blood, and how urine is produced or formed in the body, and the 20 types of or 20 colors of urine. In Arabic or Islamic era, actually Byzantine period, or we can say the Middle Age when we say, which expands roughly from 5th to 15th century. The Islamic era is simultaneously, we can say, it expands from 7th to 13th century. The same time, almost the same time or same era, Islamic or period or Islamic civilization was flourishing on the Arabian land, while the Byzantine civilization was flourishing on the European land. That's why in the content slide, I have written the three words by Middle Age, then slash Arabic, then slash Islamic era. As we know, in the golden age of Islamic era, which roughly spans from 8th to 12th century, in which lots of contribution by Islamic era physician has been done to the medicine. And some notable physician of that era were like Rabban Tabri, who has written the Firdaus al-Hikmat, and Abu Yaqub Ishaq ibn Sulaiman al-Israeli, who is known in West as Isaac Judaeus. He actually has written a treatise exclusively on the examination of urine, or on the urine, with the name or with the title Kitab al-Bawl, in which he has mentioned the formation of urine and the types of urine. Then, as we all know, Zakaria Razi, Ibn Sina, Ismail Jarjani, Ibn Rushd, these are the names which are those are the person who have contributed a lot in medicine. Zakaria Razi, in his Kitab al-Murshid, Kitab al-Mansuri, even in Al-Hawi, the most of the part of 19th volume of Al-Hawi is dedicated to urinary changes. And also in 10th volume of Al-Hawi, where he has described the urinary system diseases, there also he has mentioned urinary changes regarding diseases or diagnosis, we can say. In Kitab al-Murshid, he has also mentioned that those who want to master the uroscopy, they can simply refer his book Kitab al-Buhran. And Ibn Sina in his book Al-Qanun, Ismail Jarjani in his book Zakhira Farizam Shahi, and Ibn Rushd in his book Kitab al-Kulliyat have given a very detailed description of the urine examination. Formation of urine, as we can see how urine is produced in the body and how urine is formed in the body is as we know, Huzume Arba are the 4 digestions. Whatever we eat, actually, it goes under extensive processing in our body so that it can replenish, so that it can be used for the replenishment. So these extensive processing of the food inside our body is divided into 4 levels or 4 stages, which we call 4 digestion. And the first digestion is the gastric digestion, in which food processing occurs inside the alimentary canal. Then it is sent to the liver, where further processing of callus, the first, that is gastric digestion. As a result of gastric digestion, callus is formed, and this callus is transferred to liver for further digestion, we can say, or further processing, so that it can transform into humors. And then this humor is transported to various through the vessels to different parts of the body or different organs. So inside the vessels also there are some transformation, there are some processing takes place. So that processing inside the vessel is known as vascular digestion. Then at the level of tissue or organs, finally, transformation from the, what we can say, humus to humors when goes to this tissue, and humor when go this tissue, they utilize for the replenishment, that is known as tissue digestion. As we know, there is callus is the product of gastric digestion, which has to transfer, which has to enter to the liver for further processing. So callus is a semi-solid material, we can say. It has to pass through the narrow mesenteric vessel to reach the liver. As we know, mesenteric vessels are very narrow. So according to physicians, tabiat or physis sends some excess water with it, so that its flow inside the mesenteric vessel become easy, or for its easy flow into the mesenteric vessel, so that it can be transferred to the liver for further processing. When callus reached finally to the liver, where humors are formed after hepatic digestion, then the liver no longer required this excess water. That excess water was just for the purpose of transportation. So now this excess water, which is no longer required by liver, is disposed by liver to the kidneys. In kidneys, the Quwwat-e-Jaziba, as we know, every organ is furnished with these Quwwa, and the kidney has one extra Quwwa, that is Quwwat-e-Mumayyiza, or differentiating faculty, which we call. So Quwwat-e-Jaziba of the kidney accept or absorb these excess water, and Quwwat-e-Masika retains this excess water. Actually, this excess water has some humors with it. So Quwwat-e-Mumayyiza actually separates the nutritive material from this excess water, which is which was actually a waste for liver. So Quwwat-e-Mumayyiza separates this nutritive material from the waste, and the nutritive material was then acted upon by the Quwwat-e-Hazma for the nutrition of the kidneys, and the waste, which is water, like liquid waste, it is disposed of by the Quwwat-e-Dafiya, and this liquid waste is actually urine. These are the parameters like color, consistency, quantity, clarity and turbidity, odor, foam, and sediments. These are the parameters that are observed in the uroscopy. Then Razi has added two more parameters like lumps, that is touch, and taste or maza in this parameter. However, these two parameters were later omitted by the physicians. Color of urine. As we know that color of urine has always been a vital criteria for urine examination to identify the pathology in the body. And Rabban Tabri, in his book Firdaus al-Hikmah, has mentioned 10 colors of urine. And according to him, colors of urine are actually based on the 4 temperaments of the body. Razi, he has described 7 colors in his book Kitab al-Mansuri, and it was Avicenna who, for the first time, categorized these colors of urine into in 5 colors, categorize the urine into 5 colors, and different shades of 5 colors actually. Avicenna actually, he defines different shades of 5 color, that is yellow, red, green, black, and white of urine, and he, like other physician, he mentioned the clinical significance also. Abu Zayd al-Masihi and Ismail Jarjani, They have described, according to them, that there are 4 colors of urine based on the 4 humors. And according to them, that urine, green color of urine is actually a compound color. First, as we know, yellow urine, and there are 6 types of yellow urine that are described by the physician. That is polythibiny, which is a straw color, straw yellow color urine. It looks like a water in which a straw has been soaked, and it actually indicates the coldness in the body. Or some of the physician has written that it indicates the khafif nuzj, or we say, or incomplete nuzj. Then Utraji, citron yellow urine, which actually indicates the moderate heat in the body. And actually, this is a normal color of urine. Then Ashkar, Ashkar Naranji, Nari, Zafrani, or Ahmar Nase. These 4 urine actually indicate the hotness of the body. However, the level of hotness increased from Ashkar to Zafrani, and so the redness of the urine increases from the Ashkar to Zafrani. As we know that in modern times, or in present, it is established that in urobilinogenuria and in excessive sweating and in fever, urine becomes yellow or orange. In Boleslav, red urine, there are 4 types of red urine are described by physician, and that is Bole Ashab, Bole Vardi, Bole Ahmar Qani, and Bole Ahmar Akhtam. Bole Ashab, that is slightly yellowish red urine, or Bole Vardi, which is rose red urine, Bole Ahmar Qani, interest red urine, and Bole Ahmar Akhtam, that is blackish red urine. And all these kind of red urine actually indicate the dominance of blood in the body or the hotness of the body. As we know that sometimes ingestion of some food also turns urine red, like ingestion of beetroot. It has also been described by the physicians. And hemoglobinuria and hematuria turns urine red, as they have described the dominance of blood is one of the cause to turn urine red. Then green urine, Bole fistaqi, which is pistachio green urine, Bole asmanjuni, that is leek green urine, and Bole neelji, which is emerald green urine. And all these 3 urine are caused by excessive coldness. And Bole korasi, which is dark green urine, and Bole zanjari, that is verdigris green urine. And these 2 urine, actually 2 types of urine, indicate the extreme hotness in the body, or the combustion or ihtiraq in the body. And Ibn Sina has also mentioned that sometimes green urine actually indicate the poisoning. And it is now established that in phenol poisoning, urine turns green. And in jaundice also, urine appears green, a color of urine change to green. Bole Abiyad or white urine, Bole Abiyad Haqiqi, and Bole Abiyad Mushif. Bole Abiyad Haqiqi, in which we cannot see through the urine. It's actually a translucent urine, just like a milk, or its whiteness is like a milk. We cannot see through it. It is thick, usually in consistency. Mostly it indicates the expulsion of the phlegm in the urine, or sometimes dissolution of fat in the body. And Bole Abiyad Mushif, it is a transparent urine that indicates the cold temperament and sometimes defective maturation. And other classification of urine, white urine, has also been given, like Bole Mukhati, which is mucus or phlegm-like urine, which indicates the immature phlegm is being excreted through urine. And Bole Dasmi, that is fat-like urine, dissolution of fat or phlegm as occurs in the last stages of Dik. And Bole Fukai, which is wine-like urine, wounds of urinary tract, it indicates. And Bole Manvi, that is semen-like urine, that indicate the crisis of some phlegmatic swelling has occurred. Or sometimes it also acts as a warning sign in case of sakta and fallage. Bole rasasi, which is lead-like urine. Actually, this urine, color of this urine is white with some greenish hue. And the dominance of phlegm, it indicates the dominance of phlegm, which is mixed with black bile and is being excreted through urine. Bole labni is it is milky urine. Appearance of the urine is like a milk, and it is fatal in acute fevers. And sometimes it also shows that Safra has diverted to some other organ other than the urinary tract, and which will show the sign of inflammation in near future. Bole ihali, actually this type of urine looks like olive oil, and it indicates the forthcoming death in acute fevers, especially in dip. Bole ghosali, it looks like water in which flesh has been washed, and it indicates the weakness of liver and kidney. And some of the physicians actually argued that bole ghosali is not a type of white urine, but it is a compound color urine. Black urine, as most of the time, black urine follows some other color of urine. If it follows yellow urine, that it indicates the burning of bile. If it follows the bluish color urine, that it indicates the dominance of black bile. And if black urine follows the red urine, that mostly it indicates the burning of blood or black bilious sanguine. So usually in case of excessive combustion, or we can say excessive hotness or ihtiraq, or intense cold, or sometimes even in extension of innate heat, and a crisis or expulsion of black bile by tabiat, and sometimes even consumption of black wine leads to excretion of black urine. And as we know, alkaptonuria is one of the cause of black urine. Consistency. So far as consistency of urine is concerned, urine may be dilute, it may be concentrated, or it may be of the moderate consistency. So the dilute urine usually indicate the excess fluid intake, or sometimes it indicates the immature humor in the body, or some obstruction in liver vessel has occurred, or in children, especially in febrile children, it indicates the renal failure. And as we know that physicians were of view that the urine of children is supposed to be concentrated as compared to the adults. And the reason they have cited that children actually, they are in a stage of growth and development, they take more food, and the eating habit of children is irregular. So their digestion and metabolism is not as optimum as the adults. So it leads to expulsion of or excretion of the farm, we can say, or some immature humor in their urine that makes their urine thick. So Ibn Sina has written that in children, dilute urine is not a good sign. Concentrated urine, as we know, in high-grade fevers, dehydration, or in severe illness, in high-grade fever and dehydration, urine become concentrated because of the in high-grade fever, as we know, sometimes water has evaporated through some other means. That's why it turns the urine concentrated. And in severe illness, it indicates the poor prognosis, and mostly it indicates the incomplete concoction of the matter. And sometimes even the concoction of the thick matter leads to excretion of the concentrated urine, as we can see in the last stages of Mahiyatul, or even in rupture, in case of rupture of an abscess, urine becomes concentrated. And moderate urine, actually, it indicates maturation or concoction of the matter, or maturation or concoction of urine. Volume, Volume should be normal, but sometimes it may be decreased or maybe increased depending on the condition of the body. Normal volume of the urine indicates that adequate water has been taken and the faculties are operating at optimum level. And decreased volume actually indicates the less intake of water, weakness or failure of the faculties. Diarrhea, excessive sweating, exercise, strenuous work, and hot weather, these are factors actually make the urine volume of the urine small, or we can say low. Increased volume, excess intake of water, excessive dissolution, as sometimes use of diuretics increases the volume of urine. Clarity and turbidity. Clear urine, adequate digestion and concoction it indicates, and it signifies the absence of any disturbances in the body humus. That cloudy urine, it usually indicates the improper digestion and absence of concoction, and even weakness of faculties and weakness of innate heat, even inflammation of the internal organs, and sometimes headaches. As mentioned by Lamakarshi, that in headaches, urine become cloudy, and he has given a name that is Bole Kadir Mutasawwir, I think. Next is the odor. Normally, urine has a characteristic odor, and that indicates concoction and maturation. It is not established that fresh urine has an aromatic odor, and which is because of the volatile fatty acids present in urine. And sometimes the urine becomes fetid, or urine has a fetid odor. Then it indicates the wound in either wound in urinary tract or putrefaction of humors in the vessels of the body. Urine sometimes become odorless, and at that time it is because of either excess coldness or extinction of innate heat in acute diseases. As it is written by Razi, that fetid urine accompanied by itching and pain around the bladder and purulent urine are the sign of bladder pustule, that is Jaibimasana. And sweet odor, pungent odor, and sour odor of urine indicate the dominance of sanguine, bile, and black bile in the body, respectively. Foam or froth, normally the number, size, color, and time of bursting of bubble actually indicate the condition or various condition of the body. Like presence of froth in urine is a sign of viscosity of humor. And greater the viscosity of the urine, larger will be the size of bubble. And also these bubbles will not burst easily. And the number of bubbles increases with an increase in viscosity and gases. And an increased viscosity, as you know, is a sign of renal disease. As I have already mentioned in the previous slides, while I was talking about the Hippocrate, where I have mentioned that presence of a bubble on the surface of urine is a sign of kidney disease or long illness. So he used to assess the froth of urine also. Sometimes even color of bubble indicate condition or pathological condition of the body. Like in jaundice, the color of froth is dark orange. Then sediment are actually the solid component of urine. When we see the urine, then urine, there is a two component. One is the liquid component and the other is the dense or solid component of the urine. The solid component of urine is actually termed as sediment, and as the liquid component of urine is considered as a product or a waste of the hepatic digestion, whereas the sediment is considered as a waste of third and fourth stages of digestion. The physician used to apply the term sediment to anything that is denser in consistency as compared to urine or liquid part of urine, and which is either suspended in the middle or floating on the surface or settled at the bottom. They used to term it as a sediment. And the nature, quality, quantity, form, position, time, and admixture of the sediment provide clues about the body's various states, as I have already mentioned the Hippocrates statement regarding the sediment. And they have actually divided these sediments into two types, that is benevolent sediment, that is Rasub Mahmood, that indicates the complete concoction, and Rasub Ghair Mahmood, that is malevolent sediments, which actually indicates the kham akhlat, or we say the immature humors that are present in the body, or the dissolution of some organ, or they have written that melting of the organ usually. Then the collection of urine. As we know that most of the physicians of Islamic era or Arabic era, they have described the conditions that should be met while collecting as well as examining the urine. And two names like Ibn Sina and Ismail Jarjani, these two physicians have given a very detailed description regarding collection of urine. The method of collection that is given by Ibn Sina and Ismail Jarjani, some of their points we can say is now even followed now. They actually written that the vessel or the collecting pot in which urine has to be collected, it must be dry and clean and spacious. So the whole urine can be collected into a single vessel for examination. And they have mentioned that urine must be of the whole night and collected in the early morning, and it must not have retained in the bladder for a long time. And they also describe some do's and don'ts, like they have mentioned that patient must not have taken either food or drink before giving a sample for examination, and patient should not have taken any coloring agent or like any food that may turn urine color, that may change urine color. Like I have already described that beetroot may turn the urine color red. They have also mentioned that patient should not have been taken any drug which expels some humors like musile balgham or musile safra or musile soda. And patient should not have done any physical or mental exertion, because it may also alter the color of urine. Like even fasting, wakefulness, excessive wakefulness, anger, all these factors change the urine color from normal to lemon yellow or red in tint. Even they have also mentioned that urine must not be examined immediately after collection, because they consider some of the physicians suggested that it should be kept not more than 6 hours, and some of the physicians suggested that it can be some of the physicians actually suggested, like Ibn Sina, he suggested that urine must be examined within 1 hour after collection. And Ismail Jarjani was the first person who actually recommended the 24 hours urine collection, which is now in use for different pathological conditions, for the diagnosis of different diagnosis as well as prognosis of different pathological conditions. And So far as shape of the collecting pot, they have also described what shape of the collecting pot would be. Like Ismail Jarjani and Rabban Tabri has mentioned that the collecting pot should be shape of collecting pot should be similar to the shape of the bladder, so that the environment of urine would not be changed much. They have also even described the urine of various animal in their books, because at that time, as uroscopy was a thing, or we can say uroscopy uh, was the only diagnostic tool for the physician to assess the patient or to diagnose the diseases. So there was common that patient used to bring the animal's urine or fake urine just to test the skill of the physician. That's why in many of the books, like in Zakhira Farizm Shahi, in Al Hawi, there are description of the urine of uh, various animals. So they actually thought that physician must be aware of the appearance of urine of animals, so they can differentiate it from the urine of humans. As I have described here, the views of the, or we can say the uroscopy, what described by the physician of Islamic era. At the same time, we can say in 12th century, there was a French scholar named Gilles de Corbeil. He actually classified 20 different types of urine based on sediment and color. He introduced the term matula or matula. Matula is nothing but the urine collecting pot, or parura we say. Matula, a glass vessel to collect urine for assessing color, consistency, and clarity. De Corbel believed that different parts of the matula represented different areas of the body. He actually marked or divided the matula into 4 parts. And according to him, that upper part of matula actually represent the upper part of the body, lower part of matula represent the limbs of the body, and the middle part of matula actually represent the middle or trunk of the body. So the changes that appear in the upper part of the body is actually represent that there are some pathology in the upper part of the body, like head and neck. And he also wrote a poem on judgment of Uranus, which is very famous. There were also some authors like Constantinus Africanus in 11th century who has written Destruction Medici, in which he has mentioned that urine was better than pulse to discover the disease from the patient who suffers. Bernard of Gordon, he was 13th century physician. He also stresses the importance of examination of urine in diagnosis of the diseases. Then Peter Reveres, who wrote the Judicial of Uranus, and then Maester Robert Ricorday, who wrote the Urinal of Physique, and John Fletcher, his book is very famous, The Differences, Causes, and Judgments of Urine. However, in these books, mostly they actually recapitulated the earlier knowledge. Nothing more new was included in this regarding uroscopy. Then Renaissance era. Renaissance actually is a French word for rebirth, and it roughly expands from the 15th, or we can 15th through 17th century, or some places it is mentioned that 14th to 16th century is the Renaissance era. It was the era when it signifies the fall of the Byzantine Empire, which I have already mentioned that Middle Age, which signifies the Byzantine period or Byzantine Empire, which after fall of the Byzantine Empire, Renaissance era started. And this was the era when Europe was actually reviving its art, its culture, and its medicine. That's why it is given, the name is given as Renaissance era. It was the era when uroscopy entered the household through the Decatham's book Fasciculus Medicinae. Decatham was a German physician who actually wrote a book. In his book, he included a diagnostic color wheel by which individuals could self-diagnose their condition. This is the diagnostic color wheel. But soon after introduction of this color wheel, it hit the market and entered the household, and misuse of uroscopy started. And people started using this chart. They started using this chart to diagnose their diseases by themselves. And they also started using for the purpose of the fortune telling, for the purpose of the witchcrafting, even for the therapy. Every kind of misuse of urine started, and examination of urine for the purpose of the fortune telling is actually known as the uromancy. And this practice of uromancy is also started in Renaissance era. And there were physicians or there were scholars who actually opposed the misuse of uroscopy. And that led them to wrote many books like Thomas Browne in 17th century has written a book, The Piss Prophet, just to oppose the practice of misuse of uroscopy. And there was also a book that is called as Piss Pot Prophet. In this era, actually, where one side the misuse of uroscopy was going on the other side, the reformation of uroscopy was getting underway. Like it was a time when proto-chemists were very active at that time, and they were in search of philosopher's stone, and most of you must be aware of the philosopher's stone. And they used to have their laboratories, bizarre laboratories. So in those, in their laboratory, the analysis of urine began by them. The first thing they did was the comparison of weight of urine to that of rainwater in 15th century. And this actually comparison of weight of urine led to discovery of, we can say, the urinometer in 19th century. Then these were all about the physical examination of urine. As we know that even now in physical examination, volume, color, turbidity, odor, pH, specific gravity, and osmolality are examined or observed. And next is the chemical analysis. I will be talking how the chemical analysis started. So as we know that for chemical examination of urine, tests for glucose, protein, ketone bodies, and bilirubin and urobilinogen, bile salts, blood, nitrite, HB, etc. Is examined in the urine. So as we can say, it was Paracelsus who can be credited for the beginning of the chemical analysis. Paracelsus was the person who first rejected the humoral theory, and he believed in some chemical theory. Actually, according to him, the cause of disease was some chemical derangements in the body, and these chemicals then if they get disturbed, if their ratio gets disturbed in the body, then a disease occurs, and these chemicals then get excreted by the kidneys. He actually given the idea that mercury, sulfur, and salt, these three chemicals are responsible. These three chemicals in right proportion, they are responsible for the health of the body or maintenance of health in the body. And any disturbances in their proportion, then disease will occur. So in that case, these chemicals get excreted by the kidneys. So he gave the idea that for this purpose, chemistry of the urine needs to be analyzed to identify the cause of disease. And he did various experiments. And one of his experiments was that in which He added vinegar to urine and precipitated something, but at that time he was unable to interpret the outcome. That must have been the protein, but he could not interpret the result at that time. And two of his followers, like John Baptista von Helmont and Hermann Burhau, they actually advanced chemical analysis of body fluids. However, they choose urine rather than blood because at that time there was much literature, we can say, was available related to urine only. And there was no significant literature related to blood analysis was available. That's why they chose urine rather than blood. In fact, many of the chemical elements now reported in blood metabolic profiles by clinical laboratories were first identified, isolated, and analyzed in urine. As such, urine, which has been the first body fluid to be looked at, which was the first body fluid to be examined for the purpose of the diagnosis and prognosis, is actually the first to be analyzed scientifically, or we can say is the first body fluid to be analyzed in the laboratories. And analysis of the blood followed. First, they started scientifically analyzing the urine, and after that they started analyzing the blood. And at the urge of Robert Boyle, this is the person who has given the term analysis. Urge of Robert Boyle, analysis of urine was coupled with that of blood in order to detect their similarities and differences. Then Leonhard Therneser, he was the student of Paracelsus. He actually used a method of analysis of urine based on boiling urine in a special device, which is called as the anatomical furnace. As we can see, his device that is called as anatomical furnace is actually resembles the body of a man. And he divided the anatomical furnace into 24 different parts. And based on location of the fumes that is generated after boiling the urine and spattering, he used to locate the ailments or site of ailment. Then in 18th century, Matthew Dobson published his famous paper entitled Experiments and Observation on Urine in Diabetes in 1776, in which he established by chemical analysis that sugar was the agent responsible for sweetness. As I have already discussed in first or second slide, that sweetness of urine was first detected by the ancient Indian scholars or physician, but the chemical analysis it was established only in 1776. Then Brown Langrish, who did analysis of blood and urine during various febrile illnesses and reported them in his Modern Theory and Practice of Physique, he actually in this book, in the preface of this book, wrote that it will be highly useful in investigating the causes and the phenomena of disease. Now, microscopic examination. Microscopic examination, as we know that microscopic examination is done to detect or to identify the insoluble materials in urine. As we know that urine contains formed elements from blood, kidneys, lower genitourinary tract, and the sediment of urine that include the cells, cast, crystals, bacteria, yeast, and parasite, etc., etc. So we can say that microexamination is done to detect the microorganisms and some cells or cytology. It was Robert Hooke who was first to use his monofocal microscope to examine urine, and he reported some rhomboidal crystal in urine that was probably the uric acid crystal. And he reported in his book, Micrographia, that was published in 17th century. And but it was after the introduction of bifocal microscope that urine microscopy flourished and climaxed in the clinical studies of Pierre Rare and Eugenie Napoleon Vigla. He together actually wrote a treatise with the title Trait, These Maladies, These Reigns, which consisted of 3 volumes, and that book was published in 19th century, sometime between 1839 to 1841. And the importance of microscopic examination of urine is highlighted in this book for the everyday clinical practice. It was Alfred Don in the early 19th century, a French bacteriologist and doctor who discovered Trichomonas vaginalis and leukemia. And he invented the photoelectric microscope in collaboration with Foucault. And he was the first person to run microscopy courses for physicians and for the general public. In 1840, that is the early 19th century, RBC, pus cells, and a variety of crystals were recognized. And this was the early use of microscope in clinical practice. Urine cytology becomes a method of identification of malignant cells in various body fluids in 1853, when F. Donald published the practical application of microscope in cancer. And different cells of different parts of the urinary tract were illustrated by BL in 1854, that is early, we can say mid 19th century. And probably Lamble illustrated the malignant cells from carcinoma of bladder in mid 19th century. Leukocyte counting technique by microscope was then developed by J.D. Rand and W. Shepard. Then in 1840, bacteria were observed in urinary deposit. As we know, in 1840, bacteria were observed in urinary deposit. But at that time, their clinical significance was not much known. It was only in 1881 when the rod-shaped bacteria in urine were observed by William Roberts, and the first paper on observation of bacteria in fresh urine was published by him in late 19th century. And during the second half of the 19th century, urine microscopy was established in everyday clinical practice. And it was, we can say, the Golden Bird and Lionel Smith Bailey who actually presented important papers and manuscripts regarding the microscopic examination of urine. And Golding-Birds actually published a book with the name Urinary Deposits and Their Pathology. This picture is from his book, Element of Urinary Sediments by Golding-Bird's book, Urinary Deposits and Their Pathology, and in which he has published the pictures of crystals or oxalic acid crystals, protein urine cast, and erythrocytes. So we can say that microscope brings a revolutionary improvement in the medical science, and as we know, the rest is history. I actually, due to scarcity of the time, I'm not going in much detail, as I know that in the next lecture, Ruhi ma'am would be discussing the recent technologies. So I'm just concluding my lecture. As in this talk, I have described the evolution of urine examination over the time, or the long urine examination has come a long way from mere physical examination to the chemical analysis and to the microscopic examination and even beyond. And a renaissance of this oldest diagnostic tool of medicine is now underway due to recent technological advances, which probably would be discussed by Ruhi ma'am in microanalysis and molecular biology. I can say that by using newer techniques, the urine findings described by the physicians from the time of Hippocrates to the Islamic era in different pathological conditions can be re-evaluated to make the diagnosis and prognosis of diseases easy. Thank you. Thank you all for the patient listening.
Thanks a lot, ma'am, for enlightening us about the Thanks a lot, ma'am, for enlightening us about the evolution of urine examination over the time in such a concise manner. You connected the dots to cover the topic very well. Thanks a lot, ma'am.
Thank you.
Now our second speaker is Dr. Ruhi Azam, Assistant Professor, Department of Mahiyatul Amraz, School of Unani Medical Education and Research, Jamia Hamdard, New Delhi. Ma'am has completed her UG in 1999 and PG in Molejat in 2002 from Jamia Hamdard, New Delhi. She served as medical officer in Jammu and Kashmir. Ma'am has also served as a consultant and clinical registrar in New Delhi. She is associated with teaching since 2014. She has published a chapter and 22 research papers in reputed journals. She is also the member of editorial board, International Journal of Communicable Disease, and associate editor of International Journal of Pharmacognosy and Chinese Medicine. She has also co-supervised 2 theses till now. Now I would like to call Dr. Ruhi Azam to deliver her lecture on urine analysis and new technologies. Over to you, ma'am.
Thank you so much, Dr. Sinella, for your kind words and kind introduction.
Thank you, ma'am.
Assalamu alaikum and a very good morning to everyone. First, I would like to share my screen. Is my screen visible?
Yes.
Okay.
Yes, ma'am.
Okay, so thank you. Assalamu alaikum and a very good morning to everyone. First, to begin with, I would like to thank Professor Abid Ali sir and the Department of NIUM, Department of Mahiyatul Amraz, for inviting me to present the talk in your webinar entitled Urine as a Diagnostic Tool. As Dr. Tasfia, she has very excellently presented the historical background of urine analysis. And to further elaborate this topic, I will present a modern version of all that what she has said, how the ancient physicians used to classify urine on the different bases, whether that is physical, chemical, or microscopical. And I will be presenting the modern version, what versions we use at the present time for urine as a diagnostic tool for diagnosis of different types of diseases. As we all know that the relation between urine and diseases, it goes a long way back. The relation has been recognized by the physicians since the earliest civilization BC. In fact, it is the laboratory medicine that began thousands of years ago and started analyzing urine, as the term was used for that time for urine analysis at uroscopy, which was later termed as urine analysis. The word uroscopy derives from the Greek words, as mentioned by Dr. Tasfia, uron, that means urine, and scopia, that means to examine, to contemplate, to inspect. Our Unani physicians and other physicians of different other medicines, they spoke of urine as a window to the body's inner working and reflected different diseases. Hippocrates has hypothesized that urine was the filtrate of humors of the body that originates from humors, and it was filtered by the kidneys. He was the first to state that described the bubbles on the surface of fresh urine as a sign of long-term kidney disease, and he also associated the formation of sediments on the urine with fever. Galen has described the phase, a diarrhea of urine, to describe the excessive urination. Also, as mentioned by Dr. Tasfia, Theophilus of the 7th century physician, he wrote a manuscript exclusively focusing on urine, and he called it as De Urinis. He also determined that if we heat urine, a sediment, a precipitate is formed that at present time we called as urine. So he was the first who documented proteinuria as a diseased state. Also, one French scholar of the 12th century, Gilles de Corbeil, he was the first who classified 20 different types of urines. He is the first who invented an instrument called as matula for assessing the color, consistency, and clarity of the urine. Also, we have Robert Bright, who is known as the father of this nephrology in the 18th century. He also had done a pioneer work in the field of kidney research, and he has also published at that time a lot of manuscripts related to the kidney diseases. These examples illustrate how urine analysis was the first lab diagnosis made in the history of medicine, and how there has been a steady progress in the sophistication of uroscopy or urine analysis. From the first qualitative urine glucose test in 1850 to automated dipstick readers in 1970, from the single lens microscopy in 1997 to the urine particle flow cytometers of today, and how it continues to be the most common specimen used in the clinical diagnostic laboratories as a cost-effective tool to obtain crucial information for diagnostic purposes. Urine analysis has always been and is still a very potent screening tool for the physicians. No other lab test can provide us as much information on the status of metabolic, renal, infectious, and urological functions in the body as urine analysis. So physicians use urine analysis for everything from general screening to the cancer detection. It has, in urine analysis, we do a lot of tests that are non-invasive, and the method of collection of urine is also very simple. And a lot of tests like chemical, microscopical, molecular tests can be done besides bacterial cultures. As you know, there has been new advancement in the field of science, new technologies, new methods are being constantly added in the field of science. So this urine analysis is also changing. Because a new generation of analyzers that integrate and automate its two main primary functions have been introduced in the market. And these new technologies are opening doors to the introduction of new renal biomarkers, which will revolutionize the diagnosis of various kidney disorders, particularly the acute tubular necrosis, in the same way as cardiac biomarkers that revolutionize the diagnosis of cardiac diseases. So what we do in the uroscopy, we simply, what is urine analysis? Urine analysis is simply how we examine the physical, the chemical, the microscopic features of the urine. That is what we do in the urine analysis. There are three types of urine analysis that we do. Number one, that is the complete urine analysis, in which that is performed in the lab, and we look at the composition of the urine, total complete examination of urine in the lab for its contents, for its constituents, what are present in the urine. We go for the complete urine analysis. Number second is rapid urine analysis. That is a strip test that can be performed anywhere at one's convenience, at home, in the doctor's office, or anywhere. We use simple strips in this examination that can be used for detection of sugars mostly, and a lot of other tests. Number third, we have 24-hour urine collection that is performed mostly in the hospitals, or you can collect the urine in a sterile sample at home and then present in the hospital or the lab while you want to get tested. It gives about the clear picture about the renal function. So as urine analysis, so what we do in urine analysis, we examine the physical character, the chemical analysis, and the microscopic sediments. In physical character, as Dr. Taspia had described in the historical background, what we do in the physical examination, I will be presenting the modern version. We check the volume, color, odor, specific gravity, and in chemical analysis, different chemical constituents of the urine like pH, proteins, glucose, nitrates, urobilinogen, blood, etc. There we check that. And in microscopic segments, which is the casts, either that can be cellular casts or acellular casts, plus the different types of microorganisms that are present in the urine. First thing, as regards the volume, we know the volume of the urinary volume, or how much volume that is excreted in the 24 hours, that gives a status about the renal function. If there is any change in the volume, either if there is increase in the volume or decrease in the volume, or any other change, that signifies that our kidneys, they are not functioning properly. If we have excessive urine, normally 600, 200 ml in 24 hours, if it is above 2000 ml, then we call this polyuria, which can specify a number of diseases like diabetes mellitus, diabetes insipidus. It can be because of polycystic kidneys, it can be because of chronic renal failure, or excessive use of diuretics, or intravenous or glucose use. So by knowing how much volume kidneys excrete in the 24 hours, that can be an important clue about the diagnosis of all these diabetes, polycystic, and all these diseases. Similar way, if there's oliguria, it is less than 400 ml or 500 ml per 24 hours, that can lead us to the diagnosis of excessive acute glomerulonephritis. It can be a sign of congestive cardiac failure, or simply oliguria can be because of severe dehydration, vomiting, excessive sweating, or excessive diarrhea. And we can have one more condition, that is anuria, in which we don't have any, we have very less amount, less than we have 200 ml urine excretion during 24 hours. That can be because of a lot of conditions, like we have some structural abnormalities in the kidney, like we have renal tuberculosis. It can be acute tubular necrosis, or we have complete urinary tract obstruction. Fine. So the volume of urine, it presents us a very important and information about the diagnosis. We can make diagnosis by simply looking at the how much amount of urine is excreted by the urine by the kidneys in 24 hours. Number second important feature, that is color and appearance of the urine. Normally, they will have a slight pale color in the urine, that is presence of various pigments like urochrome, etc., as everyone is aware. Then we can have colorless urine in a lot of conditions like diabetes mellitus insipidus or excessive use of diuretics. We can have milky urine, purulent urine in the GIT infections, genitourinary tract infections, or it can be because of chyluria. We can have orange urine in case of severe jaundice, or it can be because of excessive use of carotenoids. We can have red urine in case of beetroot injection, or we can have because of hematuria, hemoglobinuria, or we can have brown or black urine in case of malignant malaria or melanin melanomas. We can have this type of urine. So just by looking at the appearance or looking at the color of the urine, we can diagnose so many diseases. That is why it has such an importance in it is important diagnostic method for assessing different types of diseases. Number third is the odor. Normally, urine has a typical aromatic odor due to the presence of volatile organic acids, and long-standing urine that also develops anatomical ammonical odor because of conversion of ammonia into urea. But besides this, if a normal urine of a fresh urine that has a fruity smell, that can give us diagnosis about the ketoacidosis, or it can be because of starvation. If we have mousy or musty smell, that can be phenylketonuria. Fishy smell represents urinary tract infection with Proteus trichomonasis, or ammonical smell, that is a sign of UTI with E. coli. Fine, or we can have other foul smelling urine is another type of infections also. We can have sulfur-like smell is cystinuria. So by smelling the urine, we can have different types of diagnosis. Number third point is specific gravity. As you know, it is 1.01 to 1.025. It is a solute concentration that is present in the urine. If it is increased, that is a sign of oliguria. For example, that can occur in dehydration, in diabetes mellitus with polyuria, or acute renal failure with oliguria. Similarly, the specific gravity that can decrease in diabetes insipidus with polyuria. Then we have the pH or the reaction, how the urine is, whether this is acidic or this is alkaline urine. Normal pH is 4.6 to 8.0. And we can have acidic urine, diabetes mellitus, starvation, in fever, in UTI, by E. coli, and we have high protein diets. So similarly, alkaline urine that can be present in chronic renal failures, that can be present in different types of urinary tract infections by bacteria that split urea to the ammonia, like Proteus or Pseudomonas, or we can have excessive vegetarian diet we eat that can again cause the alkaline urea. So the pH of the urine, that's an important clue for ketoacidosis in diabetic patients, and that can again give us clue about the different types of infections present in the urine. Fine. So as for the chemical analysis of urine is concerned, what we examine is simply the proteins, glucose, ketones, bile, bilirubin, bile salts, urobilinogen, hemoglobin, etc. in the urine. As I have already said, pH that gives that presents the partial assessment of acid-base status. Alkaline pH indicates all samples or urinary tract infections. Specific gravity again gives us a state about the kidney state and hydration status of the patient. And proteins, if we have more than 150 mg per 24-hour protein excretion in the urine, that term we refer as proteinuria. Proteinuria, if protein is present in the urine, that can lead us to the diagnosis of different type of kidney disorders, like we can have glomerular proteinuria, like in nephrotic syndrome. We can have tubular proteinuria, like in acute and chronic pyelonephritis, heavy metal poisoning. It can be because of tuberculosis of kidney. It can be because of cystinosis, or it can be because of rejection of the kidney transplant. Similarly, we can have proteinuria again in different type of plasma cell dyskaryosis. We can have sickle cell muscle traumas. We can have hemodynamic proteinuria in severe high fevers, in hypertension, congestive cardiac failures, and we have post-renal hyperproteinuria can also be there because of any neoplastic condition in renal pelvis or ureter, bladder, prostate, or urethra. So by simply examining the protein in the urines, we can get a lot of diagnosis of different types of renal conditions, and that can help in the diagnosis. Simply, if we have microalbuminuria, that is presence of albumin in the urine above the normal level, but that is defined as, or it can be defined as the urinary excretion of 30 to 300 milligram per 24 hours in the albumin in the urine. And its significance is that it's an important indicator of subclinical cardiovascular diseases, besides being a prognostic marker for other kidney disorders. In diabetes mellitus, in hypertension, fine, or if we have patients admitted in the intensive care unit, and if the increasing microalbuminuria during the first 48 hours after admission, that can, if it remains elevated, that is an acute, that can be a sign of acute respiratory failure, multiple organ failure, or overall mortality. Fine. So third important content that we can examine in the urine is glucose. Simply, this has been the oldest and the easiest method for examining the diabetes mellitus. This is a diagnostic feature. We examine. Am I audible?
Yes, ma'am.
My screen is not showing.
No, ma'am.
Am I audible?
Yes, ma'am.
Yes, ma'am.
ma'am.
Okay. Is my screen visible now?
Yes, ma'am.
Okay. So, as I was saying, glucose or glucosuria, that is again a diagnostic feature for diabetes mellitus. We can have glucosuria with hyperglycemia in case of diabetes, acromegaly, Cushing's disease, hyperthyroidism, or intake of drugs like corticosteroids. We can have glucosuria without hyperglycemia, that occurs in renal tubular dysfunction. Similarly, if we have ketones in the blood, that can in the urine, sorry, that we call as ketonuria, that is sign of decreased availability of carbohydrates in the diet, that can occur in starvation, in persistent vomiting in children, or it can occur in various weight reduction programs in which the intake of carbohydrate is restricted to the very much restricted. Fine. If it can occur in the increase in metabolic needs, like in fever, severe thyrotoxicosis, it can occur in pregnancy, or protein calorie malnutrition. So all these conditions, if we have ketonuria, and that can help in making diagnosis. Similarly, if we have bile pigments or bile in the urine, so it is a diagnosis for jaundice. Not only jaundice, but we can differentiate different types of jaundice on the basis of bile salts, bilirubin, and urobilinogen that is present in the urine. Like in case of hemolytic jaundice, we have bilirubin is absent. In hepatocellular jaundice, it is present, and in obstructive jaundice also it is present. Whereas in case of urobilinogen, that is increased in hemolytic jaundice, and it is increased in hepatocellular jaundice, but in case of obstructive jaundice, this is absent. So besides giving diagnosis about jaundice, we can differentiate different types of jaundice also on the basis of bile salts and bile pigments that are present in the urine. Similarly, if we have blood in the urine, that is a sign that we call as hematuria. It can be because of diseases of the urinary tract infection. It can be because of glomerular diseases like glomerulonephritis, etc. And it can, or if we have non-glomerular diseases also, there we can also have this hematuria. For example, in calculus, in tumors, infections, tuberculosis, pyelonephritis, and lots of other diseases where we can have hematuria, fine, or we can have other hematological conditions like coagulation disorders or sickle cell diseases. We can also have hematuria. So presence of blood in the urine can lead us to the diagnosis of either or non-renal diseases. Now, as regards the microscopic examination of the urine, we see different types of casts, crystals, microorganisms, RBC, WBC, epithelial cells, and pus cells. So what we do in this, the urine specimen is first centrifuged, the liquid portion is then poured off, and then we can go for the examination. We can have different types of crystals in the urine, like uric acid crystals, which are barrel shape or pallet shape or diamond shape. It is seen in different types of tumors or lysis. Fine, we have calcium phosphate stones. They are star-shaped or needle-like. We can have magnesium ammonium sulfate, ammonium phosphate crystals, and which are rectangular shape or prism shape, and they are suggestive of UTIs by the organisms like Proteus and Klebsiella. We can have calcium oxalate dihydrate stones also, crystals also. They are again diamond shape or prism shape, but they're not specific of any systemic disease. We can have calcium oxalate monohydrate crystals also, which are dumbbell shape, and that is seen as the ethylene glycol injection. Or we can have cysteine crystals in the urine. They are hexagonal in shape, and they are a diagnostic feature of cystinuria. Fine. Similarly, we can have different types of casts in the urine. They are basically aggregates of particles that form in the distal nephron. They dislodge and pass into the urine. In urine analysis, they indicate kidney diseases. They form via precipitation of TAM horse mucoproteins, which is secreted by the renal tubules. We can have different types of casts like cellular casts, RBC, WBC, and epithelial cell casts. Or we can have also acellular casts like hyaline casts, granular casts, waxy casts, titic casts, pigment casts, or crystal casts. Red blood cell casts, they are always pathogenic in nature, and they are strongly indicative of glomerular damage. They are They are usually associated with nephritic syndrome. You can see this is the microscopic examination of the RBC cast. Then we have WBC casts. They are generally indicative of inflammation or infection. They are typical features of acute pyelonephritis. Then we have hyaline casts. They are most common type of casts, and they are solidified TAM Hirschfeld mucoprotein secreted from the tubular epithelial cells. They are seen in fever, sternus exercise, or damage to the glomerular capillaries. This is the picture of in this hyaline cast. Then we have granular casts. They can result either from the breakdown of cellular casts or from the inclusion of aggregates of plasma proteins, for example, albumin or immunoglobulin light chains. They are indicator of chronic renal diseases. This is the picture. We can have casts. They are suggest to severe long-standing kidney diseases such as renal failure or any end-stage kidney disease. This is the shape of the cast. Then we have fatty cast. They are formed by the breakdown of lipid-rich epithelial cells. These are hyaline casts with fat globulin inclusions. They are present in various disorders like nephrotic syndrome, diabetes, or lupus nephropathy, or acute tubular necrosis. Then we can have mucus in the urine. Okay, they appear as ribbon-like threads. They are present in the urine sediments, and they are suggestive of urinary tract infection, ulcerative colitis, or kidney stones. We can have pustules in the urine. 2 to 4, they are normal, but if the number increases, they are indicative of inflammation and infection somewhere in the urinary or genital tract. Then we can have epithelial cells. These are large and flat, they appear, as you see. They are usually, they are suggestive. Again, if epithelial cell number is increased in the urine, they again suggest some sort of infection in the urogenital tract. Then certain organisms can be seen in the urine microscopic examination. They include bacteria, yeast, trichomonas, etc. These are the common microorganisms that are present in the urine. Fine. Now, new technologies and urine analysis. New technologies have paved way for a significant progress in urine analysis, and many novel and improved diagnostic technologies and tools like automated urine analyzers, automated urine sediment analyzers, chemical urine analyzers, flow cytometers, nucleic acid tests, and mass spectrometry has been introduced in the market. Beyond improving the individual patient management, new diagnostic tools have influenced epidemiological surveillance, infection control, antimicrobial stewardship, facilitation of the clinical trial enrollment, and co-development of drugs and diagnostic tests. The ability of these new diagnostic techniques to work directly with urine samples without compromising the sensitivity and specificity of the standard methods is of paramount importance. Time and accuracy, these have been the 2 key factors for the diagnosis of any type of urinary tract infection or any nephrological condition. With the invention of these technologies and new techniques, both time and accuracy, these two have achieved new heights. We are able to make diagnosis within a short duration of time without consuming much time, with more 99% accuracy. And we are able to prescribe antimicrobial therapies accordingly in a short duration of time. Fine. So some of the new technological advancements in this field of urinoscopy, urine analysis, is first is automated microscopy. As we all know that urine microscopy, this has been the most important diagnostic method for UTI and other kidney disease. Manual microscopy, as we all know, that is a time-consuming method and is also labor-extensive. And further, with the centrifugation, decantation, resuspension always leads to the cell loss and cell destruction. With the current available digital microscope techniques, and significant time has been reduced and we can examine, and more samples are being processed in significantly short time in comparison to the manual microscopy. In addition, with the ability to process uncentrifuged urine samples, issues like cell destruction, cell loss, they are not of more any concern anymore. Many automated analyzers are now available in the market with different kinds of technologies such as laminar flow digital imaging technology and pattern recognition technology. Auto analysis can be used for urinary tract screening and for diagnosing and monitoring a broad variety of nephrological and urological conditions. Newer applications also have shown a promising result in the early detection of urothelial cancer. Automated microscopy with digital imaging and particle recognition is very important diagnostic tool invented. The IRIS IQ 200 from the IRIS Diagnostics, it uses digital imaging and auto particle recognition technology to not only classify but also quantify the urine particles in uncentrifuged urine using a single laminar flow of the specimen through a lens of a charged coupling video device camera. The hundreds of digital camera captures are evaluated by identification softwares present in this tool, and each particle is classified on the basis of characteristic basics like size, shape, contrast, and texture. The analyzer software classifies images into categories including RBC, WBC, WBC clamps, hyaline casts, unclassified casts, epithelial cells, non-squamous epithelial cells, besides bacteria, yeast, crystals, mucus, sperm, and amorphous substances. Digital images of the particles are collected at a rate of 500 frames per sample, and it can be viewed and reclassified by the operator, potentially without the need for manual microscopy. The commonest used analyzers of present day time is FAS 100 and 200. And one more, SEDMAC 77, that is from Electronica Budapest, Hungary, is an automated microscopy image-based urine sediment analyzer, which is also known as Uriced in many countries. It can microscopically analyze the urine sediment for leukocytes, erythrocytes, epithelial sites, cells, bacteria, and yeasts. It shows the particles within the whole field of view, similar to the microscopic field seen with the manual microscopy. The instrument provides bright field view and phase contrast images and generate a composite image of the bright field and phase contrast microscopy images to exhibit the features of each image in one view. Number second is the second generation SEDMAX analyzer. It is SEDMAX 277, which allows the distinction between 4 types of crystals present in the urine, like calcium oxalate dihydrate, calcium oxalate monohydrate, uric acid, and citrate. However, many labs still pull the samples with pathological findings for a secondary manual microscopy. Since the sample is unstained, the appearance of the components differs from that observed by the manual phase contrast microscopy. So a trained technician and much more training in the field just to differentiate between the different types of samples, centrifuged, unstained, or stained, that is still needed. One more important feature, that since microscopic urine sediment analysis, that remains a key method for urine analysis, but unfortunately, the required expertise is not available at some odd times, like at night or at weekends or at the time of some festivals. So the electronic transmission of images, what we call as telemedicine, that can therefore be very useful for obtaining diagnostic information, enabling consultation with experts regarding usual, unusual, or some doubtful findings throughout the world among the scientific and the medical community. Number third, one more important technological tool, that is flow cytometry. Recently, urine flow cytometers, what we call as GFCs, they have been used as a reliable method for fast diagnosis of UTI by counting the bacteria in the urine specimen. With the improved counting precision over the usual counting method, highly accurate positive results with labor reduction can be obtained by this method. A rapid screening based on the detection of cells in the solution by light scattering has been employed in many of the devices, and they can detect most bacterial species as well as the fungi. One such example of the flow cytometer system is UF100, that's from Sysmex, Japan. It uses a combination of light scattering and fluorescence to rapidly screen and identify RBC, WBC, squamous cells, transitional epithelial cells, renal tubular cells, bacteria, yeast, and inclusion casts, yeast-like cells, crystal spermatozoa, and it uses argon laser flow cytometry. Clinical studies using UFCs have focused on diagnosis and monitoring of urinary tract infection, localization of the sites of hematuria and diagnosis, and monitoring and exclusion of the renal diseases. One more important, as everyone is known, is the test strip technology. We have been using test strips since a long time for the diagnosis of urine, even how much glucose, diabetes and how much glucose content. We use that qualitative analysis of urine and all that thing. But now major improvements in the test strip technologies have been made in the recent years. Not only highly sensitive test strips have been introduced, but also one can find strips which give quantitative results for the urinary proteins and ketones. Not only the qualitative, but we can get the quantitative results also, and that too for proteins and ketones. Also, the financial aspect is very important in the countries like third world and the developing countries. So these inexpensive test strips for various diagnostic reasons, such as diagnosis of diabetes from the urine sample, are now available. Test strips have also shown promising results in antibiotic susceptibility tests, we call as ASTs. And if the optimum diagnostic requirement is reached, it can reduce the time significantly from 2 to 3 days to a few hours. Recently, a dye-based albumin test strip in combination with the complementary metal oxide semiconductor CMOS-based test strip reader could allow quantitative analysis of albuminuria and also help us in the determination of albumin creatine ratio. This development enables obtaining quantitative albumin readings in the microalbuminuria range of 2 to 200 mg per liter. The creatine specific test pad allows correction for urine dilution, which is useful in the assessment of albuminuria. Using CMOS technology, very sensitive readings can also be obtained for leukocyte esterase and peroxidase activity in parallel. The use of many sensitive dyes have been introduced in the market with these test strips. So they have, on these sensitive dyes, they have improved the sensitivity of albumin strip tests. One more important instrument is proteometric method, that is matrix assisted laser desorption ionization time of flight mass spectrometry, called as Mahiyatul NS. This has been recently introduced in clinical microbiological laboratory. Mass spectrometry is a technique in which charged particles are created by ionization, and their identification is identified based on the mass charge ratio. Higher the mass, higher will be the charge. Specifically, matrix Mahiyatul mass spectrometry has been approved by the regulatory agencies for pathogen identification from culture. The technique generates a peptide mass fingerprint that is unique for each specific organism, and that can be compared against the database of the reference spectra. For application of UTI, for application in the UTI identification, the urine sample is first cultured to isolate the bacteria, and the colony from the cultured plate is then analyzed. As the time needed for culture continues to hinder the decision making and the laboratory workflow, so direct from sample characterization of the bacterial load constitutes a major advance. Several studies have explored direct analysis of urine samples using this mass spectrometry, therefore eliminating the time lag needed for the pathogen identification. This technique has been suggested as a fast and reliable method for bacterial identification, for identification of organisms directly from the culture. We don't need to wait for 2-3 days and then we can get the culture. No, we can directly identify the microorganisms from the culture. And it can identify a variety of pathogens in a short duration of time, that is 1 to 3 hours, and with 67 to 87% sensitivity. The utilization of this technology for the diagnosis of UTI and further some in performing antibiotic susceptibility tests to decrease the testing time from days to as fast as 2 hours can open wide doors. One more technique, that is fluorescence in situ hybridization, that we call as FISH, is a cytogenic technique that uses fluorescent probes that bind to the complementary sequences in the target cells, such as the bacterial or any pathogen. Fine. FISH is widely used in research laboratories and has been translated into clinical diagnostic era for infectious diseases. A common target for detection of bacteria by nucleic acid hybridization, such as 16S ribosomal RNA, that is an integral component of the bacterial ribosome that constitutes both evolutionary consequences and a region that are unique to each bacterial species. Further, some 16S RNA is present in abundant quantity, that is present in greater copies per cell. So detection is dependent on the development of specific probes, but the abundance of these species-specific sequences facilitate pathogen detection via the molecular methods. The rapid FISH assay can be processed in as little as 20 minutes with a sensitivity and specificity of greater than 96%. Then we have multiplex PCR. Nucleic acid amplification by PCR, it has been a mainstay of molecular biology and genetic research since its inception in the late 1980s. The sensitivity and specificity of PCR that enables the detection of rare targets has assisted its adoption into the clinical diagnostic applications. A role of PCR for direct from urine UTI diagnostics is being investigated by several companies that have developed systems for PCR-based detection of pathogens, that too directly from urine. One such example is SeptiFast real-time PCR that is currently approved for identification of pathogens from the whole blood samples. This multiplex panel targets both gram-positive and gram-negative bacteria in addition to a number of fungal species. To explore the possible adaptation of this platform to the UTI diagnosis, SeptiFast was directly compared with a standard culture of 82 urine samples from 81 patients with suspected UTI. Urine samples were processed without prior incubation of the incubation, and DNA was extracted from the cells in the urine sediments for PCR analysis. Concordance between two methods of positive and negative negative findings in the gram-positive and gram-negative and fungi were 90%, 97%, and 97% respectively. The SeptiFast test has a sensitivity and specificity of 82% and 60% respectively for the detection of infection. SeptiFast identification was available at least 43 hours before the culture result. You can imagine how fast this test is. And if it has been, labs are working on this for rapid identification and detection of the pathogens. And when pathogens are detected at an early time, the drugs or the antibiotics can be started and that can lead to the patient recovery at a very fast rate. One more example is of biosensors. That's a molecular device composed of a recognition element such as an antibody or nucleic acid that binds specifically to a target analyte like nitrate, etc., and generates a measurable signal via a transducer. For quantitative detection, the magnitude of the signal is proportional to the analyte concentration. Biosensors are an excellent option for integration into diagnostic platforms as they enable manipulation of small volume fluids, short assay time, low energy consumption, high portability, and multiplexing. Further, some smartphones can be integrated into these technologies as a controller unit and readout instruments to enable low-cost point-of-care application for biosensors. Then we have laboratory on a chip. That is in view of the great need for the development of portable and cost-effective readers, pocket-sized calorimetric readers can be combined with dipsticks in a device that is able to transmit digital information via a smartphone, offering an integrated solution for detecting diseases in areas with limited access to the trained experts. Advances in microfluidics have enabled the development of new chip-based assays, which will alter the field of automated analysis in the near future. Alongside conventional urine analysis, applications like integrated microfluidic chips have been described as a promising tool for measuring the concentration of blood cancer cells in the urine samples. Similarly, microfluidic paper analytical devices have been designed and fabricated for evaluating bacteria known to cause UTI like E. coli and sexually transmitted diseases like Neisseria gonorrhea in human urine samples. Studies exploring the possibility of establishing a smartphone-based diagnostic platform for rapid detection of Zika, chikungunya, dengue virus showed valuable perspective. Several other smartphone applications utilizing urine analysis for various diagnostic reasons have been tested and is showing promising future perspective, which can greatly help both medical practitioners and patients alike. Then we have potential biomarkers for urine analysis. Many renal pathologies like acute kidney injury and associated tubular nephropathy can lead to the imminent kidney failure and death. The traditional method of supporting physician assessment of kidney function like BUN and creatinine have significant disadvantages as they take 24 hours. They take so much long time, and even after 24 hours, it takes 24 hours for creatinine level to rise, even if both the kidneys have stopped their function. Alternative markers have been proposed like neutrophil gelatinase associated dipocalan, that is NGAL, and we have KIM, that is kidney injury molecule, and we have IL-18 and cystatin C, but none currently replaces the creatinine as a marker of renal function. Urine cell analysis is only alternative at present, but a very useful but very helpful test for identifying evidence of kidney disease. Ordinarily, there are very few formed elements in the urine. However, if we have acute kidney injury, then renal epithelial cells can be shed into the tubular lumen and detected in the urine. Red blood cells indicating glomerular inflammation or breakdown, WBCs that indicate infection, REC cast and granulocytes can be quantified in very low levels with automatic urine analyzers. Besides providing biomarkers for renal biomarkers in the urine analysis, we have identified some cancer biomarkers also in the urine analysis, like protein 53, protein 21. We have P27, MMP, that is serum matrix metalloproteinin protein 9. We have ApoE, and we have all these other cancer markers also in the that has been analyzed, that is being investigated in the urine. So if these markers they are being available to everyone, and so research is going on about the application of these markers in the renal field or in detection of cancer, in detection of renal cancer or detection of any other renal pathology, so that can revolutionize the field of medicine, just like these cardiac markers have revolutionized in the field of cardiology. So just to conclude, I would like to say that urine analysis has a dynamic future. New technologies for instrumentation, new biomarkers, new methods are being developed that aim to provide patients with a timely diagnosis and tailored antibiotic therapies. With the advances in today's technology over the past few decades, automated urine analysis has done a remarkable technical process. Both microscopy and flow cytometer-based instruments generate reliable results that are clinically useful, and merging automated test strips with the smartphone technologies can lead to the tremendous change in the healthcare system and can deeply integrate point-of-care testing into the health system, providing added value. Further, some advances in the screening tools such as flow cytometers, mass spectrometry, and nucleic acid tests, multiplex PCR that can lead to great achievements not only in the diagnostic field by providing much faster and accurate results, but also they can contribute greatly in the medical and biomedical research fields. Thank you so much for being patient audience. Thank you so much.
Thanks a lot. Thanks a lot, ma'am, for making us aware of the new technologies. It was very, really meaningful and knowledgeable lecture. Thanks a lot, ma'am. Proceeding further, our third speaker is Dr. Sanjida Tabassum ma'am, biochemist, NIUM Bengaluru. She did a PhD in biochemistry. She worked as laboratory specialist in King Abdul Aziz Naval Base Hospital, Kingdom of Saudi Arabia, from 1997 to 2004. She has also various published research papers in reputed journals. Now, I would like to call Dr. Sanjida Tabassum ma'am to deliver her lecture on diagnostic role of microalbuminuria. Over to you, ma'am.
Assalamu alaikum. Am I audible? Am I audible?
Yes, ma'am, you are audible.
As you have heard about a lot of lecture.
Your voice is not audible. Please speak a little louder.
Voice is wrong. Hello. In the morning, you must have heard a lot of lecture on urine and the importance of its analysis in the view of Unani aspects as well as modern aspects. Now, I would like to give a lecture, a small brief lecture on diagnostic role of microalbuminuria, a small topic from the whole of urine analysis. It's a very interesting topic. So let me talk about microalbuminuria and its diagnostic role. So before we go into the details of it, let us know what is the role of albumin in the blood. The albumin is the most abundant protein that consists of about 66%, which is made in the liver and released into the bloodstream, where it binds to various molecules for different functions. Microalbumin is a very small amount of the same protein albumin that the kidney excretes if there is some damage in the kidney. So let us see what is the importance of albumin in the body. The importance, albumin is a very important nutrient for cell growth, tissue repair, for building the muscles, and to fight infections. Albumin also carries various substances such as fatty acids, hormones, and various other ions to different organs of the body. Many of other substances also get attached to albumin for transportation, including certain medications, example, warfarin. So albumin has a very versatile role in the body. So now let's come to the diagnostic role of albumin in the whole body. So albumin levels in blood helps assess liver and kidney functions and also evaluate the nutritional status of a person. Ideally, Albumin should be at a concentration of 4 grams per deciliter in blood plasma. Severe inflammation from a number of conditions such as sepsis or burn injuries may also cause a drop in the albumin level in the blood. Now, if we come to the albumin level, it is normally present in blood. Albumin should be present in the blood. It should not be in urine. So, albumin in urine is called albuminuria or proteinuria. And the micro levels of the same albumin in urine is called microalbuminuria. What is microalbumin? Let's come to the details of it. Microalbumin is nothing but a tiny amount of the same albumin which is excreted by the nephrons of the kidney. If the kidney filters are damaged, protein passes into the urine. So microalbumin is used diagnostically to test for kidney functions and to evaluate fluid balance of the person. Microalbuminuria is thought to be a marker of widespread vascular damage and reflects the systemic transcapillary leakage of albumin. On a standard urine dipstick, only 10 to 20 milligrams of per deciliter is the minimal detection limit of protein. So urine dipstick method, you usually ignore if there is microalbumin. So we have to go to the details of microalbuminuria. We have to go for a special test for microalbuminuria if you have to detect the minor levels of protein in the urine. So what is micro and macroalbuminuria? The same microalbuminuria is the small quantity of albumin that is excreted in urine. Macro is nothing but proteinuria, it's the same thing. Microalbuminuria is the laboratory diagnosis which is defined as urinary excretion of protein, albumin, between 30 to 300 milligrams per day or 20 to 200 milligrams per liter in a randomly collected sample. Usually for a person, the urine collection will be about 1 liter. So with 30 to 300 milligrams per day or 30 to 300 milligrams per liter is the same. So macroalbuminuria is nothing but proteinuria. A value more than 300 milligrams per liter is commonly called as albuminuria or proteinuria. And this indicates severe kidney damage. So let us see the comparative table for albumin and microalbumin. The definition is the same: protein synthesized in the liver and released into the blood. This is albumin. Microalbumin is the small quantity of albumin that is excreted from the kidney to the urine. Normal levels in the blood, it should be 4 milligrams of albumin per deciliter of blood plasma. About 30 to 300 milligrams in 24 hours. It should be less than that in microalbumin. Type of test. It's a blood test. For albumin, usually we carry out the blood test. For microalbumin, we have to carry out a test on urine. So the type of sample that we have to collect is normal blood sample. And for microalbuminuria, we have to collect a sample, a random sample or a 24 hours urine sample. The diseases that are indicated by proteinuria or microalbuminuria. The inflammation of the kidney or liver diseases, inflammation of the kidney or liver disease or malnutrition is a major cause for albuminuria or proteinuria. Microalbuminuria indicates early kidney disease or the complication of diabetes, which leads to nephritis. So let's see how we detect it. In the normal level, in 24 hours urine, for the normal patient, for the normal person, it should be less than 30 milligrams. But the first early morning urine sample, it should be less than 20 milligrams per liter for the normal patient. And we even carry out albumin creatinine ratio to assess it more accurately. So it should be less than 30 milligrams per gram for a woman, 20 milligrams per gram for men. But in microalbuminuria, the microalbumin level is between 30 to 300 milligrams. In the first urine sample, there is a random sample. It is around about 20 to 200 milligrams per liter. Albumin to creatinine ratio is 30 to 300 grams per gram for women, 20 to 200 grams per gram for men. Macroalbumin, which is nothing but proteinuria, is above 300 milligrams, which is detected above 300 milligrams. So normally when you do a dipstick test, we ignore this microalbuminuria. Now, in the first urine sample, first early morning urine sample, it is more than 200 milligrams per liter. The albumin creatinine ratio is usually 300 grams per gram for women, 200 grams per gram for men. Microalbumin in repeated samples indicate early progressive kidney disease. We have to repeat the sample. Just in once, if a person is having microalbumin, if you have detected the microalbumin level, some levels of microalbumin in a patient, you're not supposed to go for the treatment. You have to repeat the sample because maybe due to some transitional cause. So in the urine dipstick method, whatever you do, the microalbumin will be negative. The microalbumin level will be negative. So it is between 30 milligram per day to 300 milligram per day is not detected in the urine dipstick method. Only beyond 300 milligrams per day is detected, as shown, it is albuminuria or proteinuria. But this in between, the normal and the positive, this is in between. So this is called microalbuminuria, the trace amounts of albumin that is present, which alerts that the kidney disease is progressing. Now let's come to the filtration. Most of the albumin is degraded and reabsorbed by the proximal tubule, and only a small amount of protein is filtered at glomerulus. A number of conditions can cause increase in urine protein excretion, alteration in glomerular membrane permeability, glomerular capillary hypertension, or reduction in tubular reabsorption. Now, let us see the structure here. In the healthy kidney, the albumin stays in blood. So only the other excretory materials get excreted in the urine. But in the damaged kidney, as the filters of the kidney are damaged, the albumin gets filtered off into the urine. The albumin gets itself filtered off into the urine sample. So that is an indication of early kidney disease. Microalbuminuria does not show any major symptoms. That is the reason it is very difficult to detect microalbuminuria. So it does not show major symptoms. Microalbuminuria does not cause any major symptoms, but it is important to have regular tests. If a patient is diabetic or hypertensive, a diabetic or hypertensive patient should go for the test at least once in a year, which we usually don't do it in this part of the country. In this part of the world. Usually in the Western countries, they go for the microalbuminuria test every 6 months for a diabetic and hypertensive patient. Here we ignored this test. So I wanted to discuss the importance of microalbuminuria and its role. Diabetic patients with a microalbuminuria are 10 to 20 times more likely to develop proteinuria. So the causes of albuminuria. What are the causes of albuminuria? I told you it's diabetes type 1 and type 2, high blood pressure. Apart from this, obesity and metabolic syndrome. Other than that is genetic inherited kidney disease. Some of the patients will have inherited genetic kidney disease. So microalbuminuria is a manifestation of diffuse endothelial cell injury. So this endothelial cell injury causes the microalbumin, the albumin level, to increase in the urine. So this causes systemic vasculature and renal vasculature. With a damage in the systemic vasculature, which leads to interstitial albumin leak. Renal vasculature, the leakage in this, that leads to microalbuminuria, which is a risk factor for both hypertension, progressive hypertension, cardiovascular disease, chronic kidney disease. Metabolic syndrome, as you all know, metabolic syndrome, which causes endothelial and epithelial injury, leading to protein leakage in the micro level, that is called microalbuminuria, which leads to coronary heart disease and chronic kidney disease, which may be the cause for. This can be a diagnostic tool for coronary heart disease. Microalbuminuria, detection of microalbuminuria can be a tool for coronary heart disease or chronic kidney disease. See, there are other causes as well. Obesity. Obesity can also be a cause for microalbuminuria. Obesity causes hyperglycemia, hypertension, hyperfiltration. All this leading to intraglomerular reactive oxygen species and intrarenal ANG2, which leads to glomerular hypertension and then to microalbuminuria. So obesity is also one of the causes for microalbuminuria. So now let's see the major causes and the minor causes of microalbuminuria. The major cause is the kidney disease, diabetes type 1 and type 2, high blood pressure, obesity, preeclampsia in pregnancy, that's hypertension in pregnancy, minor or temporary cause, which is vigorous exercise. If a person has gone to gym for the first time and has come for the blood test here, blood and urine examination here, you can see the raise in microalbuminuria levels. If there's high fever, UTI, the urinary tract infection, or if a person is dehydrated a lot, that causes temporary raise of microalbumin levels in the urine. So diabetes affects the kidney. So how? At the glomerular level, the protein here gets excreted. The protein here gets excreted in urine. In the normal urine, in the healthy normal patients, only the urine is filtered and the rest of the protein stays in the blood. But if there is a leakage with the membrane or the glomerular membrane damage, if there's a damage in the glomerular membrane, that leads to protein excretion in the urine. So let us see why. What is the importance of microalbuminuria for diabetic patients? See, if a person is having diabetes for about 15 years, in the first 2 years, you will not be noticing any change in the protein levels in the urine. So as the years pass by, within about 5 years, some of the patients who are having diabetic patients will show the levels of microalbumin in urine. But macroalbumin, that is nothing but protein in urine. You cannot detect the protein in urine, only the microalbumin. Microalbumin can be detected. So microalbumin can be detected after a span of 3-4 years. You can detect microalbumin in urine for the diabetic patient, but macroalbumin, that is nothing but protein, cannot be detected. So that is the importance. So it starts the role of detection in the early stage. You can detect the progressive kidney disease at early stage if you start doing the microalbumin tests. Study on early nephropathy, microalbuminuria in non-diabetics. So let us see acute ischemic stroke, prevalence and prognostic significance. There have been a lot of studies which have been done on acute ischemic stroke. Microalbuminuria was long known to be a marker for nephritis. It's important in other disease processes revealed itself in further conditions associated with cerebrovascular disease has been in focus. The study was to assess the prevalence of microalbuminuria in acute stroke and to evaluate its prognostic significance. So we can do a number of studies on this microalbuminuria in different conditions. This study found The 47% of prevalence of microalbuminemia in acute ischemic stroke after other factors which were confounded it was excluded as far as possible. There was a significant association and correlation of microalbuminuria with the severity of the neurological deficit so that it may be useful as a prognostic marker. The causes for microalbuminuria. There are some modifiable causes, which is hypertension, race, ethnicity, male gender, older age, low birth weight. These are the non-modifiable causes of microalbuminuria. Causes for transient, that is temporary microalbuminuria. Recent major exercise, urinary tract infection, febrile illness, congested heart disease, acute severe elevation in blood glucose, acute severe elevation in blood pressure, and rarely due to heavy menstrual bleeding. Factors that cluster with microalbuminuria. There are some factors which cluster with microalbuminuria, that is insulin resistance. If a person has developed insulin resistance, there will be more chances of having microalbuminuria. And central obesity, low HDL levels, high LDL levels, and endothelial dysfunction. Test preparation. For how will you prepare a patient for the test? Collection of urine into a sterile container, either over a period of time or once in the morning. The patient can eat and drink normally before the test. No special preparation is needed prior to the test. So it can be done randomly. The microalbumin test is a sensitive test that assesses kidney function and catches an early sign of nephropathy. Microalbuminuria. If your patient is having microalbuminuria, the diet that is required. Most patients in the early stages of kidney disease need to limit the amount of sodium in their diet. Some patients may need to limit protein in their diet as well. If the kidney disease gets worse, patient may also need to limit potassium or phosphorus in the diet. The therapy, what is the therapy for this? So screening of diabetic patients for microalbuminuria should occur in the primary care setting, so which we normally don't have it. So we have to have microalbuminuria screening for the patients in the primary care setting for the diabetic and hypertensive patients. Reduction of microalbuminuria in diabetics may retard its progression to overt diabetic nephropathy. Angiotensin converting enzyme inhibitor and angiotensin receptor blockers therapy is the most effective measure. These drugs also provide protection against the cardiovascular problem that are highly prevalent in these patients. Prevention of microalbuminuria. To maximize the prevention of microalbuminuria, the following factors can be instituted. First, blood pressure should be maintained at 130 to 130/80, and the patient should be on a low salt or moderate potassium diet. Second, if the patient is diabetic, maintain the HbA1c, that is glycosylated hemoglobin level, should be maintained below 7%. Third, for obese patients, a weight loss program should be instituted to achieve a body mass index of less than 30. Lastly, the physician and patient working together should maintain LDL cholesterol at less than 120 milligrams per deciliter and at less than 100 milligrams per deciliter if the patient is diabetic. For the normal patient, if it's not diabetic, less than 120 will do. If the patient is diabetic, less than 100 milligram per deciliter for LDL level to prevent microalbuminuria. Diagnostic rule. Microalbuminuria is an early sign of vascular damage and a predictor of worse outcomes for both kidney and heart patients. It's a biomarker of increased cardiovascular risk. It's an indicator of insulin resistance and increased renal and cardiovascular risk associated with metabolic syndrome. What does it signal? What is the signal that you get if you have microalbuminuria? So early sign of chronic disease, kidney disease, and risk of coronary heart disease. Patients can have microalbuminuria. Hello? Patients can have microalbuminuria for years without getting any worse, and some can get even better. Without treatment, it's more likely to progress to advanced kidney disease. So detection at the early level is very important. The long-term complication of chronic kidney disease can include problems that affect the heart and blood vessels, as well as bones, nerves, and muscles. Final stage of kidney disease, patients may need kidney transplant or dialysis. It can take years for kidney disease to progress to this stage, and it happens only in small numbers of patients with kidney problems. So microalbuminuria is the first sign that your kidneys are being damaged. So having treatment and making changes to your lifestyle can help slow down and reduce the risk. The take-home message. Presence of microalbuminuria is a marker of endothelial dysfunction and a harbinger of markedly enhanced cardiovascular risk. All patients with diabetes or hypertension should be screened for the presence of microalbuminuria with a morning urine sample at least once a year. To maximize prevention, first, blood pressure should be maintained at less than 130/80, and the patient should be on a low salt and potassium diet. Second, if the patient is diabetic, maintain the HbA1c level, the average blood glucose, level to be maintained less than 7%. Third, for obese patients, a weight loss program should be instituted to achieve a body mass index of less than 30. Lastly, should maintain LDL cholesterol level at 120 milligram per deciliter if patient is diabetic. Note, most important is most patients may not show any symptoms until the kidney disease is advanced, which is why early testing is critical. Thank you all for your patient hearing. Hello.
Yes. Thank you, ma'am, for sharing a detailed description of microalbuminuria with us, as it is considered an earlier sign of vascular damage. It is also the marker of general vascular dysfunction, and nowadays is considered a predictor of worse outcome for both kidney and heart patients. Now, proceeding towards the end of this webinar, I would like to call Dr. Sadiq Ali, Associate Professor, Department of Mahiyatul, Amraz, for a vote of thanks. Over to you, sir. And at the same time, I'm sharing the feedback form also. Over to you, sir.
Honorable Director, respected HOD, teachers, participants, and my dear students. Assalamu alaikum wa rahmatullahi wa barakatuh. The best and beautiful things in the world cannot be seen or even touched. They must be felt by heart. Thank you is one such prayer among them. I deem it a great honor to propose the vote of thanks to all who have helped us in making this webinar such a resounding success. First of all, I would like to express my gratitude to our director, Professor Abdul Badur sir, for giving us an opportunity to organize this event. This webinar is the result of his scholarly and research interests. Thank you, sir, for your interesting and thought-provoking address. I would also like to thank our beloved HOD, Mahiyatul Amraz, Professor Abid Ali Ansari, sir, for his moral support and guidance. I would like to thank our distinguished speakers, Dr. Tasfiya Hakim Ansari, ma'am, Dr. Ruhi Azam, ma'am, and Dr. Sanjida Tabassum, ma'am, for making excellent presentation and making this webinar interesting and meaningful. I would like to thank Dr. Azizur Rahman for making this webinar a great success. I consider it a great privilege to propose a vote of thanks to all the participants who have witnessed it as a memorable and successful event. Finally, I am happy to express vote of thanks to our wonderful students who have made this webinar a grand success. Thank you.
कंक्लूड कर दीजिए।
So it concludes the webinar. Thanks a lot, everyone, for attending and patience listening. We hope you have learned and enjoyed the webinar. Have a great day ahead. Thank you. Thank you, everyone. Feedback form is shared in the chat box, so you can fill the feedback form. Thanks, everyone.